Ik zou dan het woord willen geven aan James Glover en John Nwobo, die een gezamenlijke presentatie gaan doen. Zij komen allebei uit Ierland. Zij weten dat James eigenlijk uit Schotland komt en John eigenlijk uit Nigeria. James is een scheikundige van opleiding, maar op een bepaald moment ontdekte hij dat hij liever met mensen dan met plastiek wou werken. En heeft een heel belangrijke rol gespeeld in het aanpassen van zorg aan de aanwezigheid van etnische minderheden in zowel in Schotland als in Ierland. John is eigenlijk een kinesitherapeut die ook een heel uitgebreide managementervaring heeft rond het managen van projecten, onder meer voor het bereiken van equity in de zorg. The floor is yours.
Hello everybody. So I'm James Glover and I am from the Irish National Health Service, and my colleague John, who will talk shortly. We're both general managers in the Irish Health Service, and we have deliberately dressed as ordinary people today to try not to look like general managers. I'm sorry, I will not make any more jokes. Jokes through interpreters never work. What we're going to talk about is perhaps a different approach to the one used in Italy. Now, what you've seen is a fantastic description of a really good approach to embedding equity in a range of different health services in Italy. And Antonio has described the complexity of that work and the challenges of that work in a very complex health environment with hospitals, community services, regional authorities. John and I are going to talk about a more local approach. I wonder if we could bring our slides up. Thank you. So, the approach that John and I are going to talk about is more from the bottom up, from the front line upwards. And the reason we took that approach rather than the top-down strategic approach used in Italy, in Emilia-Romagna, is top-down approaches in community healthcare in Ireland. They don't really work. It's very difficult to make top-down approaches work in very dispersed community healthcare teams. So our approach is quite different, and you'll hear us discuss that. John will talk first mainly, and he will describe to you an approach an approach aimed at looking at the values of individual staff. So our behaviours, our awareness of ourselves, the things that we think are important, both for ourselves and for our work. This really was our starting point. And we took a national approach and we applied it locally in our area. And we'll describe how we did that. What we'll also do is talk about how we evaluated that, how we measured our progress. Now this is very important because our staff, our people are scattered across a really big area. It's very difficult sometimes to capture success and progress. It's very difficult to capture that. So from the beginning, we felt it was important to evaluate, to measure, to monitor, so that we could work out what was working and what wasn't working. And from that, we identified some learning and some recommendations. And we hope that our learning and recommendations will be useful for you, because we think our approach could probably work anywhere. So, just for a couple of minutes, just to talk about about Ireland and the context for equity and person-centredness and migrant health. Ireland is a population of about 4.5 million, so the whole country would fit into the region described by Antonio. It's a small country. Ireland has a long history of migration outwards from Ireland. There are Irish people everywhere. Every country, there are Irish people. You go into any city, any city in Belgium, and there is an Irish pub. There's an Irish pub 200 meters from our hotel. Okay? And Irish people are everywhere. But relatively recently, that reversed, and people started going to Ireland. And now Ireland has a surprisingly diverse population. But a relatively small proportion of those migrants have been here for for a couple of generations or more. Most migrants to Ireland have arrived very recently. Myself included, because I'm actually Scottish. And John is from Nigeria. So we're both migrants who have benefited from the opportunities that Ireland has to offer. We have a country that until recently was quite poor country, that until quite recently people had to leave to find work and opportunities. Suddenly Ireland found itself wealthy, relatively, and lots of people wanted to come and work there, and the population is expanding rapidly. Ireland has the second youngest population in the EU. The average age is about 36, 37 years old. That's much, much younger than most other European countries. So the result is that we have a huge population that has come in that are mainly younger. Many of those are migrants for work, but the challenges in accessing healthcare and benefiting from healthcare are very similar to here. Ireland has been slow compared to some other countries in addressing this situation. So we have a lot to learn from Italy, from Belgium, from Canada and Australia. We have a lot to learn. We're starting from a low place. But nevertheless, there has been some really good progress recently. And on the screen here, you can see some examples of some of the work that is happening in Ireland. This is really, really good work. We have our second intercultural health strategy, national intercultural health strategy. And that's really shows some great progress in the last 5 to 10 years in trying to change healthcare so that it's much more flexible to meet cultural needs. We also have a Values in Action program. Now this Values in Action program is one of our most important elements for our approach locally in trying to improve the equity of our community health services. And that's because the Values in Action program is about helping staff understand what their own values are, and then understanding what the values of the organisation are, and trying to make them more similar, trying to help staff understand the importance of the organisation's values, and hopefully that will influence their behaviour. Then we have person-centredness. So this is a great graphic here. The writing's very small, but person-centredness, this is a national program to try and get services to be much more person-centred. Now, many of you are from clinical backgrounds. Are many of you from clinical backgrounds? If you're clinical, can you please, if you're nursing, physiotherapy, occupational therapy, medical, can you hold your hand up? Yeah? A few? Okay. That's good. So, when you are training, and when you are practicing, you hear a lot about person-centredness. It's in clinical education all the time, but often people find it very difficult to actually practice in a truly person-centred way, because often you're thinking, I haven't got time to do what this person wants me to do. I haven't got time to explain and say again, this is what you have to do. Because I have my manager saying to me, oh, you're too slow, you're far too slow, you need to work faster. Or you're worried about the waiting list for your service. And what this national program is trying to do is trying to give local services the resources and the skills and the knowledge to be able to make services more flexible. And if they're more flexible, they can more easily meet clients' needs and be more person-centred. And then we also have staff engagement. So we're doing a lot of work in the Irish Health Service to listen to staff concerns, to understand the challenges that staff face and trying to do their job from day to day. So there's a lot going on nationally, and we're really pleased that this is happening, because it gives the work that we have done locally, it gives it an anchor, it gives it a foundation, and we can use these national programs to drive our local changes. So the National Intercultural Health Strategy is very comprehensive. It's about 120 pages. And it has a number of goals to try and strengthen the capacity of the health service in local areas to make their own local improvements. And this has been really helpful for us, because it's given us an idea about the things we need to focus on locally to try and improve the flexibility of our service, the responsiveness of our health service. And we used many aspects of this in our work to create our local strategy, our local approach. But the key thing to remember is, and I'll tell you about this shortly, is that although these were helpful, these national policies and strategies and plans, actually the most important thing was what our own staff were telling us. Because we built our approach from the ground up, and that's what we're going to talk about. So, I'm going to hand you over to my colleague, John, and John's going to talk to you about our Values in Action program and how we use that as the foundation for our approach towards person-centredness and equity.
Thank you very much, James. My name is John Nwobo. I'm glad to stand before you to speak this morning. This is my first time in Belgium. This is my first time in Brussels. I think you guys are wonderful. Well done. Thank you for organizing this, Hans. All right. The few Belgians that I've met are quite respectful. They just say hello and hi. I remember when I came to Ireland initially, very friendly people. But then I went to the west of Ireland a little bit. It was difficult to, myself and my wife, we went to the west, and we were looking to say hello to people. and then people look at you in the face, and then they put their face down. Alright, so let's get out of this place before they... But it's wonderful. Thank you very much for your time. I'll speak to you this morning on Irish Health Services in the area of values. Now, I'll tell you the fundamental principle that guide what we do. We believe in, that's a fundamental principle. We believe in Ireland that to do equity and person-centered has to come from a place of value. We believe that you are before you do. So you do from your being, not the other way around. So that if we understand who we are, in terms of our value system, in terms of our beliefs, then it makes it easier for us to become more person-centered and equitable. So that equity is not what we ask people to do. Person-centered is not what we ask people to do. But being equitable and person-centered becomes who we are. And from that place of who we are, we respond to every human being, it doesn't matter who they are. So that's a fundamental principle in the approach that we have in Ireland, which is, can we go back to our identity? Can we go back to who we are? Can we go back to our belief system? Can we go back to understanding ourselves first? And from that place of understanding, respond to the needs in our community. Now, that place of understanding for each one of us is a range of many things. All right, it has a lot of spectrum from here to there. But it's important that every one of us go back to that place to understand where we are in the first place, in that spectrum, and begin to work on ourselves as we work with the people that we work with on a day-to-day basis. And we believe then that it is only on the basis of that you have sustainability, you have a culture of equity and person-centeredness, not just what we do. Because sometimes you have equity reflecting as what we do to people. We do it to migrants, we do it to this, we do it to. So, but we're not talking about ourselves in the space of that being equitable and person-centered. So that it is work to us. No, it should actually be who we are. And from that place of who we are, we respond and meet the need in our community. All right, so that is a fundamental principle on which the principle of equity and person-centeredness is embedded in the Irish health system. So to try to do that, the Irish health system identified 4 core values. All right, we know, of course, that for these 4 core values are values of care, compassion, trust, and learning. Those are the 4 core values that guide Irish health system. All right, so and on the basis of these values, we work on a day-to-day basis to try to meet the needs in our community. Now, in our area, Community Healthcare East, James will talk about a little bit about our area when he's going to do his own presentation. But I'll just go straight into this one. We did a snapshot of our culture, particularly in the staff culture. Like I said before, we are starting from the place of staff, more so than the place outside. If we start from staff, then because we are the ones who engage with migrants or engage with any other person, including our colleagues in the workplace, then our value system will be key to the things that we do. All right, our identity, who we are, becomes central to how we relate to people. The issue of equity and person-centeredness is an issue of relationship as well. Is an issue of how do we, when we see people, how do we see them? In what way do we see them? Do we see them in the context of that they are at least first of all equal, before we even talk about equity in terms of what is involved in it. So we looked at our culture in our workplace among staff this time, and we saw that 98% of the staff say that they often see their colleagues as doing extra kind thing. Only 8% report that their colleagues manage their stress well, so that it doesn't affect other people. 6 out of 10 people wish that more of their colleagues were aware of how their actions impact on how other people feel, and 71% report that toxic attitudes are seldom or never challenged. Those last two, in fact, from the third one, from the second one, the second, the third, and the fourth, will give you then a sense of where we are. Even though we have a value system of care, compassion, trust, and learning, but one thing is to have a value, another is also to live it. So you have espoused values, but also lived value is not consistent with the value system that we espouse. Because that's what that means. Yeah. So we can do the talk, but it's about how we relate to one another that makes the difference, actually. How, they say people don't know, people don't feel very much what you say to them, but how you make them feel is what they remember when they leave your presence. So it's about attitude. How do we relate with one another? And because, again, of the culture, you have 71% report that toxic attitudes are seldom or never challenged. So in the workplace, things could be going wrong. People are not happy with what is going on. People are not comfortable with certain actions that are going on. But then nobody challenges it. And we're talking about care, compassion, trust, and learning. How can we actually go and become caring, compassionate, trusting, and create a learning culture if we can't even challenge ourselves in the workplace as to what is not going well? So we need to start inward in order to be able to effectively address the situation that is outward as well as we meet people from outside. So now we make 2 decisions in the Irish health system. The first was to translate our values into behaviors that everyone could adopt, because values will always reflect in behaviors. So we have to understand what our behaviors are. And then the second was to start with a social movement to ensure these behaviors become a way of life for all of us and a visible part of our everyday actions in the health system, in the workplace. So how did we find out the right behaviors for ourselves as an organization of Irish health system? Number one, we reviewed staff and the patient and service user feedback and data. We also reviewed our policies and procedures. We established the outcomes that these policies supported. We tested with staff and patients and service users, and then universal and make a difference. These outcomes that will make that are universal and will make a difference to the staff, and behaviors that will be universal and make a difference to staff and patients. So we identified 9 behaviors. Behaviors that are personal to us, behaviors that we would engage with our colleagues, and behaviors that we will engage with patients and service users. It is important because the only way you can know a value system is through behavior. It's through an attitude. When people behave, then you know where they're coming from or whatever is going on. And behaviors are visible. Yeah, you can see that. And then if you can see it, then it's possible to challenge it. And that's what we believe. So these are 9 behaviors we expect ourselves to live by. And these are the things that we want to see in the workplace at all times. And if they are not there, then we would ask questions, why is this behavior not there? And when we find it, we acknowledge it, we recognize it, we say this is good, and can we do it more? So that in that way, we would create a culture in the workplace that supports our value system. Now, all of those behaviors certainly is intended to support human flourishing. We want to come to a place where we all are flourishing in the workplace. Everyone flourishes. Because we know there is a relationship between staff flourishing and the patient, and patient outcomes. Now, in the terms of patient outcomes, it doesn't matter what now. It doesn't matter who. Whether you're a migrant, whether you are not a migrant, at the fundamental level, we are first of all human beings. So if we can come from that place of value system, then we can treat one another with that kind of mindset. All right. So values in action is not a training program. It's not another one of those corporate initiatives. It is not a communications campaign. Values in Action is a social movement. All right, it's a social movement. How? James talked about top-down and bottom-up. In the context of Values in Action, we are looking more towards the bottom-up collective piece of work. But there are top-down structures, because you do need those structures as well to help you move some things forward at some point. But the critical part of it is the top-down, is the bottom-up part of it. It is more about, let me see, how did we do that? I'll explain that to you now. HSE recruited one man, I think his name is Leandro Herrero. He's Spanish. Pardon me for the way I pronounced it. Leandro Herrero. He published a book called Viral Change. That book is called Viral Change, the alternative to slow, painful, and unsuccessful management of change in organizations. You can Google that. If you Google Viral Change, you will get this book published by this man. And he is an author in the area of social movement and social action. And we engage with him with HSE. What I mean by we, I mean the Irish health system. We engage with him to come and set up this social movement in the workplace that will enable us entrench our values and our behaviors in the workplace and make it work for us. In creating that social change, it means that we have to have behaviors which we already have identified in him. There has to be a social movement approach which he is putting in place for us. But then also it has to be grassroots, peer-to-peer led actions. Why are we setting that up? Is to build a culture in the health service and community healthcare that creates more positive workplaces for our staff and that delivers better experiences for our patients and service users. So who is leading the change? How did we do that in terms of that social movement context? We identified highly connected and highly influential staff, who we call champions, by asking their peers to nominate them. We sent out questionnaire into the staff population. If you look into your workplace, you will know that there is somebody in your workplace that you always go to talk to about certain issues that are in the workplace that you don't like or you like, or things that are happening around you, even with your family that you engage with. There are people, you may not be a line manager that you discuss these things with, but there are key persons in the workplace that kind of attract people to themselves all the time. And people go to speak to all the time about issues that concern them, about things that are going on in the organization, about change that they're looking for. They may not be there, but these are leaders in the workplace. But they are not leaders to the extent of occupying a position in the organization, but they are leaders in terms of influencing and can actually influence the culture and attitude of the person. You end up speaking to somebody and you come away better. But you haven't spoken to your line manager, you haven't spoken to the organization, but you've been speaking. At the end of the day, you are the one who comes away better. So that is the person we call them champions. So these are staff were asked to name their colleagues that they respect, admire, and turn to for support and guidance. These are our natural leaders as nominated by their peers. Our champions have been drawn from all grades, all disciplines, all professions. It doesn't matter, it doesn't have to be the MD of the organization, you can actually be the potter in the workplace. It has nothing to do with grades. And then they will use their peer-to-peer influence and natural leadership skills to spread the behaviors in their own networks. The Values in Action survey was sent to 1,601 staff who work in the community healthcare east. From the survey, responses were identified. The top 20 most influential and highly connected people in this group were identified. 158 of them have now been chosen to become our champions in their workplace. All right. Why do we have to use behaviors? Because we know that behaviors are something people do. They are concrete. They are visible. people understand what is meant by them, and everyone can adopt them. You find out that in the workplace behavior, they say monkey see, monkey do. What you see done in the workplace is eventually what you adopt in the workplace. It's called workplace culture. If it's a toxic workplace, you overall, over time, even though you may not be one for toxic workplace, you find yourself kind of getting into that kind of mode. So behaviors are things that people can adopt. So we learn our behaviors by copying those around us. We imitate their behaviors and copy them most unconsciously. So, and that is why we're using behaviors now to try to change the culture in our workplace. Because we know that when we identify good behaviors, we try to promote those good behaviors. Where we see behaviors that are not consistent with the 9 that we have identified, we give ourselves permission to challenge those behaviors and to try to make change happen in the place. Now, these values in action in our area, community healthcare is, we started it this year, so we haven't quite fully evaluated it. But it was started in the west of Ireland prior to ourselves. This is the outcome for what they have done in the west of Ireland. So our behaviors are embedded. Champions told us that they live the behaviors and what they see their colleagues doing. So 98% see their colleagues consider the impact of their actions on others. That's an increase of 12% from what it was prior to that time. 2 in 3 see their colleagues putting themselves in other people's shoes, an increase of 23%. It is now the norm to use my name and your name. One thing that we identified patients complained about was that doctors, physios, whoever would come around them, but they don't introduce who they are. They don't even know the names of their doctors. They don't know the names of their clinicians. They just come and do things to people. We don't consider them humans, so don't even engage with them at that level to even say what our names are. All right. So, but that has increased by 47%, and then 7 in 10 are able to keep the patients informed. Sometimes patients visit clinicians and they walk away. They don't even know what next. What is the next? For me, what happens to me after this first engagement with yourself? That has also improved. And also, we're now more able to challenge toxic attitudes and behaviors in our workplace. That has increased by 15% as well, which to me is very, very significant. Because if you're able to challenge toxic behaviors in your workplace, then you are really on the right track to making positive change happen in the workplace. And for organizations that are kind of all these large, big, stratified, structured organizations, it's difficult to always have that kind of way where you can challenge behaviors now. So if you can create that space where that happens, you are making good impact. So if you want to look us up on the Twitter, or send something or find us on the Twitter, we are there at HSE Values. That's our Twitter, and then the website is in that place as well. If you want to have a look at who we are, what we do, and how we work with our value system. I'll hand you back over to James to speak about the second part. Thank you.
So John has described really well a really effective approach to getting staff to think about themselves, to think about their values, and to relate those to the values of the organization. Now, why is that important? Why is that useful for our work to improve the way that our local healthcare services meet the needs of our population? Well, what we're trying to do with this is really change the structure of our organization. We're trying to break down the hierarchy. These, you work in the health service, and health services in all countries are very, very rigid. They have very strong hierarchies. I know the pay grade of my boss, and I know the pay grade of my boss's boss, and I know that my boss will only do this because that's what's within their pay grade. And the whole health service works like that. So we need something like this to break it up. We need something like it to shake the system and put much more flexibility into the system. Okay, that's really, really important. So why are John and I encouraging this? When we are managers, really, as managers, we should want our staff to do what we say. We should be able to say, right, do this, this, and this, and our staff will go away and do it, and they won't question us. Okay? Or really, do we actually want that? Is it perhaps better for our staff to work in the way that they were trained, to work using their knowledge and their skills, and to help people, to treat people, because that was why they became clinical staff in the first place. It was to help treat people and make them better or help them live with their health conditions. So for John and I, it's better to have a much more flexible, loose structure where people are more autonomous, where people can make more of their own decisions, and they don't need to check everything with us to say, oh, can I do this? Can I do this? Can I do this? Okay? We don't want that. And the Values in Action program, which is now really picking up momentum in our organization, is going to be an incredibly useful way to help create that flexibility and that confidence in our staff. So, taking the Values in Action program that John has talked to you about, and looking at the national strategy that I was talking about before, how did John and I take all that, how did we take all of that there and then make it work in our local area? That's what I'm going to talk about for about 20 minutes, and then it's time for a break. So you've got 20 minutes of me, and then it's coffee. So just hold on for 20 minutes. So our organisation is called Community Healthcare East. And I'm going to tell you a little bit about Community Healthcare East to give you an idea about where we work and the challenges that we face. This is Ireland, here. And Ireland is divided up into a number of health areas. And our area is number 6 here. This is Community Healthcare East. This is Dublin. Dublin here. Has anyone been to Dublin? Yeah, okay. So our area covers part of the city, but also part of the countryside, the rural area outside the city. And our population is about 400,000 people. About half of that lives in the city, and about half of that lives in the country. Now this area is quite an interesting area because it has some areas of very high wealth, and it also has some populations where there's a high level of deprivation and poverty. So it's an area of great contrasts. We have also some of the most highly urbanized districts, but also mountains and tiny villages on the side of a mountain, or people living in real rural isolation with very poor transport. So ours is a fascinating contrast, an area of fascinating contrasts. We have one of the most diverse populations in Ireland. We have about 17% of our population is from non-white Irish backgrounds. Many from Europe, many from South America, and many from East Asia, Africa. It's a real mixture of people. And that diversity is increasing all of the time. It's increasing very fast. And that's creating some interesting tensions in communities in our area. Also, we have the oldest population in Ireland. Our area has the highest proportion of people aged over 65, and by far the highest population of people aged over 85. So we are the most diverse, we have the oldest population, we have some of the wealthiest population, and we have some of the poorest population. So it's a real mixture in our area, and that gives us real challenges in the community, in delivering community healthcare services to that huge range of people is quite a challenge. So our area, it includes centre of Dublin, very, very nice. Dublin is a very cultural city. John doesn't know this, but if we finish our slides on time, he and I are going to sing some Irish songs. And it also includes some beautiful, beautiful countryside. So the Wicklow Mountains, for example, this is the Wicklow Mountains. Very, very beautiful. And here is a public health nurse on the way to see a client. So the challenges that we face in delivering healthcare in our community are very significant. This picture here this pretty much sums up the challenges that we have in our area, in Community Healthcare East. I have about 800 staff. I'm responsible for about 800 staff. And they are working from places like this. Our infrastructure is old. There's been very little investment in our infrastructure. Our IT, our technology, is very, very poor. We don't really use computers, right? Everything is on paper. All of our assessment forms, our documentation, our client records, we receive referrals by fax. Does anyone here still have a fax? Put your hand up if you have a fax. 1, 2, wow, amazing. You would fit well in Ireland. We still receive referrals by fax. It's unbelievable. And this is, when I said before about top-down approaches and bottom-up approaches, okay, this is why top-down approaches, like what Antonio has done in Italy, is amazing, absolutely amazing, and fully deserves the credit that it receives in WHO. What we're trying to do is from a very different starting point. And that top-down approach just wouldn't work in our community healthcare area. So we have a lack of IT, we have undeveloped processes, because our staff work across, on the side of a mountain, or as well as in urban neighbourhoods. They're very, very scattered over a wide area, and we have a lot of variation in approaches, a lot of flexibility locally, which means that it's difficult to have consistent approaches across the whole area. And there's very poor integration with hospitals. So despite those challenges, what are we trying to do? What were we trying to do when we started this work about 2 years ago? First of all, we wanted to know how primary care services, community healthcare services, could meet the needs of this increasing diversity of population. How can we do that? How can we make things better? We wanted to encourage much more person-centred ways of working, to give our clinical staff more pride in their work, more job satisfaction, and more effectiveness. We wanted to have much more decision-making at front-line level. John and I didn't want to be making all the decisions. We didn't want to be the ones saying how it should be done when we're in the headquarters, maybe 2 hours drive from a nurse working in the community. We think that more decisions should be made by frontline staff and less decisions by us. And we wanted to have much better coordination between staff so that we could get that consistency of approach across all our services. And we wanted to do that in a strategic way using a plan. So what did we do? First of all, we needed a steering group. It's the first time that this has been done in our area, so we needed to have a good range of clinical staff and non-clinical staff to help guide the development of this work. And so we had a good range of membership. We had a membership from frontline staff and from some junior managers as well, from lots of different disciplines: OT, speech and language therapy, physiotherapy, nursing, administration. And we took a very participative approach. So John has described the importance of values, and that you get much better results when people understand each other's values and when they understand how their values help make the values of the organisation, okay? John's described that. So what we did was, right from the start, we decided that our steering group should do a lot of work on their own values. So we identified the values of our steering group. And that really, really helped us. We looked at the values of members in the steering group, and then the values of people in our services, back in the teams, scattered around our area. Now, John's described how we did that. And we identified who our key stakeholders were, who are the main people that we need to influence in this, and how can we engage with them much better? How can we have more discussion, more dialogue? How can we listen more? Then we created a plan. We felt that the best way to make the plan work was not to just have a plan that didn't fit within any of the strategies and policies of the organisation. So we based our plan around this. This graphic describes the Irish Health Services standards for better, safer healthcare. Now, all of your organisations will have these. These are regionally or nationally approved standards, clinical or quality standards. You will all have those. Sometimes they won't really look at equity and diversity. Our national health standards, they don't really look at equity and diversity, but what you can do is you can adapt every one of these standards and put more content into it, put more detail into it around equity and diversity. So, workforce, we have some actions in our plan to try and improve the diversity of our workforce. The safety, we thought very carefully, our steering group thought very carefully about how to make sure that that healthcare was safe for people who perhaps didn't speak English very effectively, or perhaps people who didn't have much understanding of, of perhaps their own health, or low health literacy. Person-centred care. How much were our services listening to clients, listening to patients, so that they could then change their service to meet the person's needs? So our actions meet all of those different aspects of clinical care. And that means that the actions in our plan, not only do they help us with person-centredness and equity, but the actions in our plan actually help our whole service meet the national healthcare standards. So it's really that our plan is helping us in lots of different ways. Now, the important thing also is that because we wanted this to be a ground-up plan, a bottom-up plan, not a top-down plan, all of our teams have their own version. They all have their own local actions that they've identified themselves. We didn't say to them, right, in your team you must do this, 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 and this. We didn't say that to them. They identified those plans themselves based on their own values and their own understanding of person-centredness. And we used really creative approaches. It was important in our work to try something different. It was important not to do the same old way of working that happens in the health services, where, long meetings, lots and lots of paper, and just things that were really, they're just not very effective. So what we did, we took a much more creative approach. Now, we developed our plan using sculpture, drama, poetry, singing, art. Okay? This is how we developed our plan. Now it sounds a bit strange. It was great fun. The evaluations that we did when we were developing the plan, the evaluations we did with staff were fantastic. Staff loved it. They absolutely loved it. And the result of that was that the quality of the plan is much, much better. And staff, because they enjoyed the process of creating the plan, they're much more invested in the plan. It's more important to them. And already what we're seeing is, even just after less than a year, we're seeing some great progress with certain elements of our plan. Here's some examples of things. So we've reviewed clinical pathways in several disciplines. Physiotherapy is the first, then occupational therapy as well, to make them much more responsive and much more person-centered. And we've stripped out a lot of the pointless actions that clinicians have to do. The forms, we looked at all the forms that they have to fill in, and we said, why do you have to fill in that form? Why do you have to fill in that form? And so we asked the question so that they did less of the things that don't really add anything, and that gave them more time to do more person-centered work. We reviewed our clinical documentation to make it gender neutral. So in Ireland, for example, a form would ask you if you were if you are a woman and you were seeking a referral for something perhaps gynecological, the form would say, who is your husband? Okay. Cervical screening, who is your husband? Why do forms need to know who your husband is? So we changed the documentation, also around things like parents. So when any documentation around children, the forms say mother and father. Okay? So we changed that, and now it's parent 1, parent 2. And so really simple things like that. But actually, those things make a real difference when you're in a clinical conversation with somebody and you're asking the questions that are on the form. They make a real difference. Patients have told us that makes a real difference to how they feel, how comfortable they feel. We've promoted interpreting. We've set up a lesbian, gay, bisexual and transgender staff network. We have done some work with our local refugee accommodation centre and a detailed needs assessment of their health needs. So lots and lots of really, really good stuff that's happening in our area. Work with our traveller population. In Ireland there's quite a large traveller population. The health inequalities that travellers face in Ireland are really significant and persistent. Nothing is changing for travellers in Ireland. Traveller men still are 5 times more likely to commit suicide than the wider population. So lots of work around travellers. So the plan is really making an impact already after less than a year. How do we know that it's working? How do we know that this is effective? Well, as I said at the start of this presentation, we made sure that we put in measures to help us evaluate right from the start. We do a qualitative evaluation after every steering group meeting, and that's how we knew that the quality of the work to create the plan was really, really good. That gave us confidence that the plan was going to be effective. We focused on learning. What did I learn today? What was the learning from today? And we tried to encourage reflection and discussion at the end of sessions. Our action plan has quite clear quantitative and qualitative measures built in, so that actions are smart, specific, measurable, achievable, realistic, and time-bound. We have review dates built into it. We are now developing a service user engagement plan to get more systematic feedback from the people that use our services. And we have our ground level plans owned by each team that they've all contributed to. and we're reviewing those constantly, about every 6 months. So we can measure our progress. And from that we know that there are a number of things that are working really well with this. We know that people who are participating in this work are very motivated, and that's really important to us, because if someone is a strong advocate for this work, it makes a huge difference. John was talking about the values champions that we have all across our organisation. Some of those are managers, some of them are clinical staff, some of them are the receptionist behind the desk in the health centre. Okay? And they're much more effective if they are enthusiastic about what they're trying to do, about the work we're trying to do. We know the work is progressing well, the plan is progressing well within teams. You've already seen some of the achievements that we've made in a short space of time. And we feel that we'll have really good engagement now with frontline staff. Now, when we've done work before, much of the work that's done in healthcare organisations, the top-down work, much of that work really struggles to engage frontline staff. Okay? It's difficult sometimes for top-down strategies to reach the front line and for people to understand what their part is in delivering that plan. From our evaluation, we know that actually our frontline staff, they get this. They know about it. And they have a good level of understanding about person-centredness. And what we're doing now is we're creating that appetite so that they can do more, they feel more confident in working in a person-centred way. We're giving them more freedom, we're giving them more autonomy. But there are challenges. Not everyone, there are about 800 people in my division, but we can't reach everybody. So where there's perhaps a manager, a local manager, a junior manager, who is not really that interested or not really that engaged, it's difficult to get to the staff through that manager because they are like a barrier, they're a block. And that's been quite difficult. Even though some of those managers report to me, because I don't want to say, do this, we have to work on their values, we have to work on their attitudes and their understanding, and that really takes time. And because of that local variation, our plans, the ground level plans, are all very different. And that's a challenge as well, because it's quite difficult sometimes to get a consistent picture across the whole division. Staff do report that there's not enough time for them still. They don't have enough time to do what perhaps they would want to do, to take the time they would like to take. There's not enough time. And that's because, remember that if we looked at the challenges, some of those challenges we haven't really been able to fix. Although John and I control a lot of resources, we can't suddenly build a health centre. We can't suddenly introduce a patient IT system across our whole service. Okay? So there's limits to what we can do. We'll have to try and do the best with what we have. This is an issue, lack of knowledge about some diversity and equality issues. So we are starting from a low base. There isn't a history of diversity in Ireland. So the knowledge and skills among some staff groups, it's not great. And we need to work more on our training. So we know that now. We need to raise the skills and knowledge of our staff. And unfortunately, resources are very limited. So unfortunately, at the moment, I have out of those 800 staff, I have about 60 vacancies. And I have 60 vacancies because my national office is restricting my recruitment to staff, my recruitment into those roles. And that means that the 740 staff who are doing the work of 800 people, there's a huge amount of pressure on them to try and keep services going. And it's more difficult then. They feel that that they can't justify sometimes taking longer with a client or doing something differently. So we do have some challenges. We can't fix everything. have some recommendations. If we were going to suggest to you a way of doing this, then we would suggest, first of all, give yourselves lots of time. You're going to need a lot of time to do this. It takes longer than you think. Okay? All those discussions that you need to have, they take ages to do, okay? First of all, you need a senior decision maker, a manager, a senior manager to help you, to back you up. You can't do it on your own. Some of this stuff needs resources. It needs approval, it needs authority. Now, fortunately, John and I are both general managers, so we can do that. But when I've worked in organizations before and that authority wasn't there, that support wasn't there, it's very difficult to make changes yourselves, at the front line particularly. And you heard me say about those, there's a few managers, a few junior managers that run clinical teams on the front line. Those managers were not engaged, and they acted as blockages. They stopped the message that John and I were trying to get through. They stopped that message from getting to their staff. So you need to try and engage those people. We're still trying to do that. And you need to have evaluation in from the beginning as well, because you need to know what your starting point is, and then you need to be able to understand the progress that you've made. It's best to connect your plans to existing strategies and policies. Now that means that they have much more relevance. Rather than having all your strategies and policies here that you're working with, but over here is your completely separate strategy, equity plan, okay? That's not really going to work. Remember when I said that we anchored our plan in our national healthcare standards, okay? So try something like that. And then finally, be realistic. You're not going to be able to change everything. Many of the things that you want to fix, you can't fix them. So you just have to work with what you have. And then what next? Finally, what next? Where do we go from here? Well, we have a long way to go, I have to say. In Ireland, we have a really long way to go. We look with envy at the great progress made in Italy, in Australia, in Norway, and in some of the other settings you're going to hear. You're going to hear about some great stuff today, okay? We look at those with huge respect and envy. But we're getting there. We are making some progress now. So we're going to be reviewing our plan. It's a three-year plan. So in about in about 2 years, we'll be doing the whole thing again, and we know that we'll have made more progress. We're reviewing constantly. We're reporting and monitoring. We're sucking up all that data, all that information that shows us where we need to focus our attention. And finally, the thing that we really are very excited about is in this coming year, we're going to have a service user group that will give us some great qualitative information. So, what you've heard us talk about is we described the Irish context. You heard us discuss perhaps the characteristics of Ireland and some of the challenges that we face. John described to you a really fascinating approach based on individual values and confidence and autonomy, and how all that supports the values of the organisation. And then I described how we took that and we used it locally to develop our own local equity plans. And then hopefully we've given you some quite interesting and helpful suggestions about things that you might take back and consider in your own organisation. So thank you very much for your time.
Okay, thank you very much, James, for a brilliant, and John, for a brilliant presentation, both of you.